individualized care because, as you know, sorry about that, because as you know, one care plan may not fit all. So that is a big goal of ours to make sure it is focused on that particular individual. We take confidentiality very seriously. That is another cornerstone of our program. When discussing, what we can do for a resident and discussing their issues or problems or concerns, we always tell them it is confidential. We do not act unless the resident gives us permission. So so therefore they can feel confident that anything they tell an ombudsman is between the ombudsman and the resident unless they want us to pursue the issue. Our program value also is that accessibility. Prior to the pandemic, I was in facilities 5 days a week. I would visit a facility in the morning and a different one in the afternoon, as well as my volunteers. Unfortunately, as you guys, I'm sure you're aware, in March of 2020, the pandemic began, and that's when families, as well as ombudsmen, were not allowed in facilities to prevent the spread of the coronavirus. Thankfully, which I'll talk about a little bit later, there has since been Department of Health guidance that has specifically said that ombudsmen will never be banned from facilities again. Also, prevention. Ombudsmen are there for residents to prevent any problems if possible. So, for example, if we're meeting with a resident and they say, well, this hasn't happened to me yet, but due to the staffing, I'm afraid that this could be an issue. And we can actually work on issues before they become problems if we see things in facilities that may become an issue down the road. We also believe in empowering the resident and giving them autonomy. At the end of the day, it's the resident's care, and they should be directing that care if they have, the cognitive ability to do so. And if not, that would definitely fall to the resident's power of attorney or healthcare proxy. We focus on complaint resolution. We obviously don't just take complaints. We work very diligently to find common ground with the facility and come up with a plan that works for the resident and keeps them satisfied with their care. The last one being objectivity. Obviously, we are there for the resident. Ombudsmen do not work for the facilities. We do not work for families. We work for the resident. So the first thing we do is when we receive a complaint, say from a family member or power of attorney, is that if the resident is able to speak and has the ability, the first thing we do is actually meet with the resident in person to find out if they're experiencing the same concerns that their family members are. There are times where we'll go meet with a resident and they'll say, oh, my daughter called? No, I'm fine. I'm not concerned about that. Or yes, that's a problem, but I'm afraid of retaliation. I just don't want this, brought up to administration. There's things that ombudsmen can do that maintain the confidentiality of the complainant while still working to resolve the issue. So the administration of the program, we were established under the Older Americans Act, and that requires each state to establish an office of the long-term care ombudsman. In New York, we are administratively housed with the State Office for the Aging, and we provide advocacy services through a network of regional programs. So at the top, we do have a state ombudsman. Her name is Claudette Royal, and she was appointed by Governor Cuomo. It is an appointed position. So the state ombudsman does serve at the leisure or the pleasure of the governor. So as of now, as you know, we do have a new governor, and Claudette Royal is working with her to at this point ask actually for additional funding for our program. So she takes care of the program from a supervisory level. She does have 3 assistant state ombudsmen that supervise the regions, as well as a senior state ombudsman who also supervises the program. The program is then broken up into 15 regional programs, and one of the 3 assistant state ombudsmen is responsible for their particular regions that they cover. And then on the regional level, the Ombudsman program has a designated Ombudsman coordinator, that's myself, who I'm responsible for recruiting, training, supervising a group of volunteers that provide a regular presence in the nursing home and adult care facilities. I do also have one full-time staff member as well as one part-time staff member. So right now I have 8 volunteers, 2 paid staff, and I just received exciting news the other day that it looks like that we will be receiving a grant soon to be able to hire an additional staff, which is a wonderful thing. So the state involvement in local program operations is just, again, to basically monitor, they're directly responsible for full oversight, programmatic functionings of the program. We do have a lot of data requirements that we have to provide to the state, then who provides it to the federal government. So each regional program is housed with an external non-for-profit agency, one being with the area agency on aging, that's the Ithaca program. And they hold separate contracts with New York State long-term care ombudsman program. The local program coordinators and our certified ombudsman volunteers within each region are directly responsible, direct representatives of the state long-term care office. Just a little map of how the state is broken up. Again, we have 15 regions. As you can see, we are in the dark gray. We're region 10. And that consists, as Kimberly said, of Oswego, Onondaga, Cayuga, and Cortland counties. We are also happy to refer people who call our hotline to the appropriate coordinator in their region. So just by the numbers again, 15 regions, approximately 1,500 long-term care facilities with over 160,000 beds. That includes not only the skilled nursing, but the adult care facilities, as well as family-type homes. The state has approximately 35 full-time and 15 part-time staff statewide, and we have approximately 300 certified volunteer ombudsmen. Sadly, this was written in December 2020, and since then, we have lost a great deal of volunteers. Responsibilities of a long-term care ombudsman under the Older Americans Act is to investigate and resolve complaints. We educate consumers, providers on resident rights. We advocate for quality care in long-term care facilities, and we promote development of resident and family councils. Not every single facility, at least a long-term care facility, is required to have, organize, promote, and hold meeting space for resident councils. These are councils that meet once a month. They may ask administration to be involved. They may not. They may ask the ombudsman to be involved. They may not. That's their right. So facilities are required to have a resident council. Some facilities also have a family council, which is wonderful. Very few actually in my region, sadly, but we do have the materials, and we can assist a facility if there's family members that come forward that would like to start a family council. We can assist with that process. And a facility's responsibility to a family council is that they must offer the family council meeting space in their facility at least once a month. So Ombudsman Authority is under the Federal Older Americans Act. Again, access to all long-term care facilities without interference. And we also have access to resident and medical records, providing we have the consent of the resident. We do have a poster that's located in every facility. I ask my volunteers as well as my staff. That's one of the very first things we check when we enter a facility, is to make sure our poster is in several areas of the facility, preferably eye level, so that people could, in a wheelchair, they can see this poster with our number. And of course, we do have our local number on here as well. The Ombudsman role is to listen, be an investigator. We gather information, evaluate facts. We educate on resident rights, responsibilities, and regulations. How to choose a nursing home. We talk about staffing. We're a resource for the community, such as this presentation. We act as a negotiator, mediator, collaborator. We help to improve communication and find acceptable solutions, and act as a third-party facilitator between roommates, or other residents and staff. I do want to mention that it really is important that facilities understand and realize that when an ombudsman becomes involved, we can actually prevent a complaint going to the next level, which is the Department of Health. So it really behooves administration and senior staff to work with ombudsmen to find a resolution, because if not, again, that issue will be elevated to the Department of Health, which then has the authority to come in, investigate, and if they find deficiencies, can certainly find facilities, as well as and I'm going to talk about this in a little bit, as well as even go further with imposing sanctions on being able to accept Medicare and Medicaid dollars, providing that the offense is serious enough. We also are policy analysts. We take a look at the broader policies that impact resident life. I do meet on a regular, well, I don't want to say a regular basis, but I do meet with local congressmen, senators, assemblymen, etc., and discuss the need for additional funding, as well as we advocate for safe staffing levels in facilities. I know an issue that we did talk to representatives about right before COVID was increasing the monthly personal needs allowance for residents. It's been $50, and it's been $50 a month for years. So it's time for that to be increased. So we do also speak to representatives about systematic issues. Again, consultant, provider of information, again, advocating on behalf of residents as well as individuals and groups. We're a referral agent, broker to other agencies who may be better able to help. I do refer many times to Office of Aging, as well as waiver programs that may be able to take a resident out of a facility and provide those services, those Medicaid dollars in their own home. And my agency, Arise, which we'll talk about a little bit later, does have a few great waiver programs that can provide those services. We're problem solvers through thoughtful assisting in resolving resident problems issues by providing options and resources. And again, system change agent, advocating for concerns of residents and the need for change on a systematic level. So just briefly to talk about our role versus the Department of Health. Department of Health focuses on quality of care in facilities, where we focus on quality of life. Department of Health does regulatory compliance based on minimum standards. We focus on going above and beyond those minimal standards to ensure that every resident has the very best quality of life possible. The DOH presence is for shorter intervals. Every year, once a year, they come in for the routine survey, and they also come in for investigative complaints to investigate complaints brought by residents or family members. Sometimes the DOH does come in more frequently. That depends if a facility is on what's called a special focus list, and I'll touch on that a little bit later. Versus our program, we have a regular and routine presence. Ideally, we will have an ombudsman in a facility for a minimum of 2 to 4 hours a week, meeting with residents on an ongoing basis, as well as meeting new residents into a facility and educating them on their rights. So again, the Department of Health can provide sanctions, sanction facilities with deficiencies, whereas ombudsmen work with facility staff to resolve those complaints. So again, it really does behoove a facility to work with our program. So similar but different, so both the DOH and our program, oversight entities of long-term care facilities, we both have the ability to investigate complaints on behalf of complainants. The differences being, though, our program investigates in a much different way than the Department of Health. We look for root causes of the problems to assist in mediation with facility staff to resolve complaints before regulatory action becomes necessary. Again, if we are unable to assist a resident in solving a complaint or concern, we do many times have to refer to the Department of Health. Within our program, facilities have an opportunity for significant improvement before that next step, receiving a formal citation for a given problem. Again, our program focus is resident-centered at all times. The resident is always the first person with whom an ombudsman must discuss any complaints or concerns. A resident wishes always remain the focus and priority of any action taken by an ombudsman. And a little strange thing that people are very, I don't call it strange, but we are actually, ombudsmen are not mandated reporters. The reason for that being is, again, the confidentiality of the program. A resident might approach an ombudsman and say, I've had a staff member, they're a little rough with me when they're assisting me with my ADLs or getting me up for the day. But yet, I really am uncomfortable discussing that. So if we feel, say, for example, if a resident is being verbally, physically abused or neglected, there are things ombudsman can do to help solve these issues without necessarily breaking the confidentiality of that resident. So a big thing, permission to act. Before beginning any investigative work on behalf of the resident, the ombudsman must receive verbal permission to do so from the resident or the representative. A resident or their representative is always the first to be fully informed about how the ombudsman program can help them. And the resident or representative then needs to give the ombudsman program verbal permission to work on their behalf to resolve their complaints. Also, for us to review their records if needed, and to reveal the identity or information in order to help to resolve their complaint. The ombudsman must then document that verbal permission was granted in their documentation. So I'm not really going to go into this right now for purposes of time, but we do here listed as how we do resolve complaints on behalf of the residents. And maybe that will be for another presentation in the future, just basically meeting with the resident, getting that permission, bringing staff together, developing a plan, hopefully mutually agreeing on a solution. And that's where, a little bit of negotiation has to come in. Brainstorm, define potential solutions, execute the solution. And then after trying out the resolution, if it doesn't work, going back and renegotiating and finding an alternative solution that may solve the problem. So this is a little old, so I'm going to skip over this. I do have a slide in the presentation I have put together. Why use volunteers? We use volunteers to add a level of authenticity to the program. I have current volunteers that at one point were in facilities themselves, so they know exactly what the resident is going through. We also represent the grassroots advocacy approach that aligns with the mission of our program. Using volunteers provides more eyes and ears in facilities and assists with facility coverage. Our challenges right now are finding volunteers, keeping them, their commitment to meeting established program expectations. Sometimes finding a volunteer with the right skill set or temperament can be a challenge. It's a very, very delicate role. We want to work well with the facilities. We don't want any type of adversarial relationship with administrators, directors of nursing, etc. I mean, obviously, if we will get strong if we need to, and we push, and we always do. But ideally, facility staff will work with us. During COVID, we did remain fully available to residents and families. We were not in facilities basically from March of 2020 until about January of 2021. However, we did call on facilities on a weekly basis. I know myself, I would call the facilities, always ask to speak with the resident council president to find, get a feel for what is going on in the facility, because the resident council president has a good idea of like what is the pulse, what's going on in the facility, are residents happy, are they not, etc. So we actually absolutely did during the pandemic, while we were not allowed in, still maintained that communication with residents and staff. We did provide facilities, residents, and families with letter for accessing the program. We did virtual communication. I participated in many resident and family council meetings through Zoom, which was wonderful. We did still do our complaint investigations. We absolutely still provided information and assistance. And the Ombudsman program did come back into facilities again, pretty much actually in about February of 2021. So that's just their information, how to contact the state office. So now I'm going to go into my slides. Let's see here. Let's get out of that. Okay. Let me kind of just go backwards here because Bear with me. Oh. Stop share. Okay, bear with me one moment. Share screen. And we'll go, oh, it's right here, but then I'm not quite sure how to get to the beginning. My apologies. I'm not the best at technology. I'm still learning this all myself. So let me see how I can get back to, I'm gonna try one more thing. Again, bear with me. I'm so sorry. Oh, I can't get out of this. Let's X out of that. And let's go here to the start of my slides. Okay, here we go. All right, long-term care ombudsman program, tips for choosing facilities for rehab or long-term care, and why care plans matter.
I'm sorry, Rebecca, you're not sharing though.
Oh, if that's not on?
It might be on your screen, but it's not, you got to hit share.
Okay, my apologies. Okay, let's see, it's not that. Oh, did I lose you guys? Oh,
you're here. You just got to hit share screen and then click on your document.
I'm having, let's see though, a hard time getting to, now I'm having a hard time getting to your screen. Let's see here. Exit, minimize video. Okay. Let's see, share screen.
Bottom, yeah, you'll see a little camera on the bottom of your computer. Just click on that. It'll get back to this page.
Okay. Yes. Let's see.
Do you see the Zoom page?
I see the Zoom page and I'm on, and I did my share screen. Let's see, and I'm clicking on. All right. Can you help me for a second, please? I'm just going to get some assistance right here. Bear with me. So I'm trying to find.
Okay, you are now sharing your screen. Just pull up your PowerPoint.
Yes, that was in, I had it up. Let's see. Nope, that's not it. Nope, that's not it. That's a little LCOP one. Nope, that's not it.
What was it labeled?
It was just
here, one of those.
No, it's not one of those. It's just basically in my, they purposely had it up so that would not.
Go to your start button and go to your PowerPoint presentations. You'll have to scroll down.
I know, and I have.
Or you could just open up. Yeah, okay, go ahead. It would be under Office.
No,
No,
You don't have Office on your computer.
No. So
Seriously, all right, that's why you couldn't. All right, open up any PowerPoint then. Yeah, I don't even see a PowerPoint. So
I know.
So you don't have a PowerPoint? You have
I did. I had it. I
had it
actually
earlier.
had it. I know, right. Get off that. And,
It should be in your recent documents if you go to. So do you know where you saved it?
I I thought I shared it on my SharePoint. Let's see.
Oh, SharePoint. That's a whole different thing.
I know. That's what we,
You guys got to get Office for your computer.
I know, right? I definitely have to talk to my IT department.
Well, folks who are on, we did do a run through and she did pull it up earlier.
Yeah, so my apologies. We're getting it up.
I really don't know where it is right now. I know if you want to forsake that, I do have a couple of questions and we can talk about, just the program in general.
Yes, if you guys want to ask some questions while I pull this up, I can do that. Let's see. Let's see. Documents. Let me go to. Actually, let me try this. All right. Gotta get up there. Don't mind my email.
There's a PowerPoint up in your, go back to the screen you were just on.
Okay.
I don't think you're sharing anymore. Okay, let's forget it.
Okay, well, I'll keep doing it. You guys can talk.
I don't want you to go searching for it while we're talking. I just saw a PowerPoint up on your browser, but I don't want to waste too much time.
I know. I'm sorry. Yeah, it's already getting on 6:40. But let's see. Full screen. Let me look one more place, and then I think I got it. Let's see here. So this, and then we'll do SharePoint. Okay, can you see the screen?
No.
No, okay. Okay, can you see the screen right here?
Yes.
Okay, so I missed a couple of the slides, but I'm going to just start from here. So again, I'm the one that wrote this, so this is like just a little bit more personal. So again, what is a long-term care ombudsman? What do they do? So the definition of ombudsman is actually a Swedish word. It's loosely translated to mean representative. So the long-term care ombudsman, again, works to resolve problems related to the health, safety, welfare, and rights of an individual who lives in long-term care facilities, such as nursing homes, board and care, and assisted livings facilities, and other residential care communities. So resident rights, there's many. So here's a snapshot. Residents have the right to be treated with respect and dignity. And that means not having a resident sit in soiled pants, or when a resident is done eating, clean the resident so that they look presentable and feel good about themselves. Staff are not to speak to residents inappropriate. It's their home. They should always be treated with respect. So that is the big part of resident rights, that whole dignity and respect issue. Also, residents have the right to be free from chemical and physical restraints. Many times, facilities will maybe look to medicate a resident who has behaviors, especially we see that with residents with dementia. That's a huge issue. Luckily, the state of New York has very, very strict guidelines on when a resident can be given certain types of medications that are considered restraint. And those are basically like the Klonopin or Ativan or any type of medications that can really change, the the brain chemistry of a resident to make them more docile, more more easy to care for. And also, again, physical restraints are anything like bed rails, straps on a wheelchair, anything that would prevent the resident from, either getting out of bed, getting out of a wheelchair, etc. Residents have the right to manage their own finances. Every resident in a facility does have, like mentioned before, a $50 a month personal needs allowance if they receive Medicare, if Medicaid is the primary source of their stay. Residents who come in for short-term rehab that are being covered under Medicare or a supplemental insurance do not have that restriction. So again, residents can voice grievances without fear of retaliation. That's a big one. Many residents are very scared of retaliation, and I would be, dishonest if I said that didn't happen. Yes, of course it happens, but our office, as well as the Department of Health, takes retaliation very seriously. We don't tolerate it. If we even get whiff of anything coming back on a resident, such as, resident might, be served their dinner last as of first, or they may not be given a shower on their shower days. These are real examples of things that residents experienced as retaliation. Residents also have the right to keep their medical records confidential. Ombudsmen do, with permission, we do have access to medical records, financial records, etc. The only document that ombudsmen do not have the ability to see are incident reports. However, the Department of Health can access those. So if a complaint is elevated to the Department of Health level, they actually can come in and review those incident reports. Residents have the right to be fully informed prior to their admission of their rights, of services available, and all charges. And also, residents must be given advance notice of transfer or discharge. One of the things our office deals with quite a bit is involuntary discharges. When a resident is given an involuntary discharge, generally they're giving a 30-day notice that the facility is going to have them transferred to a different facility or discharge even to a shelter. Obviously, that is not a safe discharge. So therefore, residents have the right upon receiving that discharge notice to appeal it. All involuntary discharge notices are also sent to the Ombudsman office. I get a copy of those. And also the resident is aware that if they wanted to file an appeal, they can contact our office and we would assist them with that process. Ombudsman then would represent the resident at a hearing and make sure that the resident has that proper representation. 9 times out of 10, ombudsmen and residents do win their appeal to be able to stay in a facility, because a facility must have a very compelling reason to transfer the resident. The only reasons really a facility can initiate that involuntary discharge is if the facility can no longer meet the resident's needs. However, they must have a discharge plan to a facility or another plan that would be able to meet those needs, and they have to justify it. So a resident cannot simply evict a resident for having, say, maybe, a messy room or, a difficult family member. It has to be for concrete reasons, and it's very rare. Now, a facility does have the right to discharge a resident for non-payment, but again, they can repeal that. So, and again, the facility must offer that safe discharge. So nursing homes provide 2 types of care: short-term rehab, which obviously includes the PT, OT, or speech, or of course, long-term residential care. Long-term stays versus short-term. Ombudsman, again, assist with, just not the long-term care, but also the short-term rehab stays. And those stays are, because of recovery from strokes, heart attacks, acute conditions. receiving PT or OT for people that may have had hip, knee, shoulder replacements, etc., or even people recovering from long-term illnesses. There were many residents that were sent to rehab to recover from severe cases of COVID. Transitioning from hospital to nursing home for rehab treatment. How it works: if a hospital discharge planner feels that a resident may not return safely to their home, they're referred to a skilled nursing facility. And prior to COVID, residents and families were able to choose the nursing home from a list of facilities that that had rehab beds available. However, now due to staffing shortages and other challenges, some facilities have actually reduced the number of rehab beds available to ensure that the residents there are receiving the very best quality care in rehab. So therefore, right now, after COVID, choices may be limited. So if given a choice, how do I choose the right rehab for my loved one? My advice to families is do your research now. You do not want that last minute rush to place a resident. So, now is the time. If you have a resident at home, but, in the future, they may need that long-term care, or, God forbid they have an accident that they need that rehab to recover, to be able to go back home. You want to now know where some options would be that you would want your loved one to stay. The best resource for this is Medicare.gov. This website allows residents and families to search any facility in the USA that accepts Medicare and Medicaid funding sources. There is a 5-star rating system. Facilities are ranked on 3 criteria: staffing, health inspections, and quality of care. Read over the facility's last state survey inspection report. It is available on that website. These inspections are completed every 6 to 18 months, depending on facility's rating. The facilities that are looked at every 6 months, those are considered special focus facilities. And it's a strange thing. New York State can only have 3 facilities on that list at once. So, for example, I can say that right now, Pontiac Nursing Home in Oswego is part of a special focus list. But what they do is the state does have facilities that are candidates for that special focus list, so that when, say, for example, if Pontiac improves enough and comes on that list, the state then has another facility they can then move to that list. I can share with you right now, it is public knowledge that both Van Dyne and Bishop are candidates for being on that special focus list. So when you're looking at these reports, please take note of facility deficiencies. And deficiencies are defined as failure to meet a federal participation requirement. Examples of deficiencies include nursing homes' failure to adhere to proper infection control measures and to provide necessary care services. Most common deficiencies that state inspectors find are infection control issues. I cannot even tell you how many times myself or my staff or my volunteers are in facilities and we do not see staff properly masked for COVID, not wearing the proper PPE. And that is absolutely could quickly become a deficiency. Also, accident and hazards. When facility inspectors look at floors, are there wet floors? Are there areas that don't have properly secured handrails, etc.? Another common deficiency is lack of staff, especially now with COVID and with the mandates for staff to be vaccinated. Facilities had poor staffing, honestly, even before COVID, and now it's just been exacerbated by these mandates. Again, a common deficiency is dignity and respect. They take that very seriously. There's a lot of complaints about food quality. Investigators do take several sample meals from different services and check the temperature and the quality of everything being served. And then the big one, which I'm going to talk about a little bit more, is lack of comprehensive care plans or not following care plans that are put in place. Please know any immediate Jeopardy deficiencies. That is the most serious deficiency in a facility. An immediate jeopardy is a situation in which the provider's noncompliance with one or more requirements of participation has caused or is likely to cause serious harm, impairment, or death to a resident. There has been a lot of media coverage lately regarding a few incidences at area nursing homes. And due to the severity, the facility was put into immediate jeopardy status. And when they are in that immediate jeopardy status, they are not able to accept any residents that need the Medicare or Medicaid funding. They would only be able to accept residents that are private pay. Examples of immediate jeopardy deficiencies are, again, serious harm, injury, impairment, or death caused by negligent staff, psychological harm, abuse or neglect, or medication errors. And what I like to point out, though, is survey teams may give immediate jeopardy deficiencies based on the probability of issues that are likely to cause death or harm. It doesn't have to come to the point where there has actually been a death or anything nefarious due to the staff on duty. So how can I advocate for my loved one when they are in a long-term care or residential facility? The things I like to focus on is care plans. Always, always, always request to be included on resident care plan meetings, as well as the resident. The resident should always be involved as well. It drives me absolutely crazy when I'm asked to be on a care plan meeting and I go or I join through Zoom and the resident is not there. That's unacceptable. If the resident is able to understand, comprehend, their care and be able to express their needs, they absolutely should be in on that meeting. I also recommend for families, if possible, to visit facilities outside the normal Monday through Friday, 8 to 4 schedule. That's when facilities tend to have the best staffing as well as all the administration available. I personally, when I'm going in to do routine visits, I like to go in on a Saturday at 5 o'clock in the evening or Sunday morning at 7 a.m. I like to go and see how is it on other shifts? How is staffing on the weekends? Are residents getting dressed on weekends? Are residents given opportunities to engage in activities, etc.? Facilities may look okay Monday through Friday, again, on that 8 to 4, 9 to 5, but it's when staffing is a little bit more precarious on the second and third shifts, and especially weekends, that it's nice to go in and be able to identify problems on those shifts. I always recommend that families, as well as obviously residents, get to know staff on their unit, as well as administrative staff. It's important to know who the resident social worker, dietitian, who they're working with in therapy, and who the recreation director is, because those are great people to speak to when there's problems involving one of those disciplines. Also, I recommend that you keep an open dialogue with administration or the social worker assigned to your loved one if you see or hear anything questionable, or if you see any type of incident or things that may make you uncomfortable. So going back to the care plan, why is the care plan important? Care plans by law, skilled nursing facilities must develop a plan of care for each resident. The care plan must be resident-centered. It must be met to meet the needs of that particular resident. They're a vital part of a resident's stay in a facility for either rehab or long-term care. That's where care plans, they do provide that centralized document of the resident's condition, diagnosis, and facility goals for treatment, especially important with residents in rehab. What is the plan? What do the therapists think that the resident could benefit from therapy before being discharged to home? Care plans also measure the resident's progress, as well as enable interdisciplinary teams to customize the level and types of support for each person based on their individual needs. Care plans can be changed or have items added at the request of resident or healthcare proxy, And care plans are updated monthly when a resident is in rehab and every 3 months for long-term care residents. However, I always like to point out at any time, a resident or their proxy or an ombudsman can ask for a care plan to be held. So even if there was just a care plan, say maybe a month ago, you have every right to ask for another care plan if the needs have changed. Care plans ensure consistency of care. An important function and purpose of care plans is to ensure the consistency of care a person receives. When there's a robust care plan in place, staff from different shifts, and nowadays staff from outside agencies, can use this information to give the same quality of care and support. This allows people to receive a high standard of care, effective and responsive care and services given. Oh, that one's blank. Ignoring or failing to follow a care plan is a type of neglect and could trigger a Department of Health investigation. That's why when I speak to residents and families and teach them how to advocate for their loved ones or advocate for themselves, I always suggest to relook at the care plan. And if there's something a resident needs, for example, I had a recent case where a resident was not having their hearing aids put in on a regular basis. I had asked to look at the care plan, and sure enough, it wasn't in there. So therefore, we had a meeting. We asked that that be put in. Once that's put in, a facility must adhere by the care plan. And again, failure to do so could be a Department of Health complaint, and that is taken very seriously. So how can we, as Ombudsman, assist you or residents with care planning? Again, residents and their representatives have the right to request that an ombudsman sit on a care plan meeting. Ombudsman may speak on behalf of the resident, of course, with their permission, or we can just be an additional voice in the room to advocate for the resident's needs and desires. So what do you do if the care plan is not being followed as written? First step is you always want to meet with administration to discuss your concerns. Sometimes it can be very simple, something simple as in maybe it's a new staff member that is not familiar with care plans, although that is always a major part of any CNA, LPN, or RN training. If you're unsatisfied with that response or action, definitely contact your facility ombudsman. We then can investigate concerns and try to resolve issues to the complainant's satisfaction. And we can work hard with administration to make sure, again, that those care plans are being adhered to. If a facility is still not complying, that is when a complainant may file a report with the Department of Health. And then that is when the DOH has the power to come in and can actually cite facilities and impose civil fines on that, on not carrying out the care plan. So how do you contact a facility ombudsman? We have a hotline. It is available 24 hours, 7 days a week. It's actually a voicemail when I'm in the office, which is kind of rare because I am out in the field quite a bit. Those calls into the hotline are then immediately sent as an email to my computer, to my email. I'm able to actually open and listen to the message, and then we immediately call back residents and representatives as the calls come in. Unfortunately, right now, we are very, very busy considering we are down volunteers and we are spread thin. So we do have a outgoing voice message that does remind callers that we are not emergency responders. You may have an issue that needs immediate attention. We do the very best we can. And yes, we do kind of triage calls. So say, for example, I have a call come in with a resident that is unhappy with the food. And then the next call is a resident calling to say, oh my goodness, I received an involuntary discharge notice. I would like to appeal this. I mean, the first thing we do obviously would be to triage that, and then of course take on the case that has that urgent importance of being resolved. I do at this point would like to make a little plug for our program. We are always seeking dedicated volunteers. And the process to become a volunteer ombudsman is to first start out by, if you're interested, filling out a volunteer application on our website. We are managed through Arise, which is an independent living / civil rights organization. And again, we're non-for-profit. All potential volunteers must pass a basic background check. We just want to make sure that we're not putting people in facilities that have a criminal background or any other type of criminal activity that would not make them an appropriate candidate for an ombudsman. We do not look at, financial or any other type of credit checks or anything like that. It's just strictly criminal. I would then contact the person for an interview. I always like to have potential volunteers come in. I am very straight with volunteers. I tell them what the requirements of our program are. It is not an easy volunteer position, and people should know that. It's work. Again, we do expect certified ombudsman after being certified, trained, etc. Once a facility is chosen for that ombudsman volunteer, we do ask that they spend 2 to 4 hours a week in the facility, and we do ask that those visits are not the same time in the same day from week to week. Again, we want to keep administration on their toes so they do not know when we're coming. And again, we have 24/7 access. We do have the right to go in on a Sunday at 3 a.m. if need be. If accepted in the program, the applicant must complete the pre and post certification class, which right now is about 40 hours over the course of 5 days. We do have a shadowing component where the volunteer must shadow with a program staff for about 4 hours prior to the class, and then about 6 hours after the completion of the certification. We want our volunteers to feel completely comfortable going into facilities, and we give our volunteers complete autonomy. I mean, obviously, program staff are here as a resource, as guidance, especially if an ombudsman has a particularly difficult case they would like some assistance with. We absolutely are there to support our volunteers. After after the ombudsman has their 40 hours of classes and their 6 hours of post shadowing, that is when they receive their certification. You do receive a badge, official badge with your photo ID, as well as has the state LTCOP Department of Health, not Department of Health, but Department of Aging logo on that, and that is your official pass. We put it on a lanyard, and it is required to be worn when in a facility. Another requirement is that certified ombudsmen, as of October 1st, are now required to complete 18 hours of continuing education per year. We do provide monthly speakers for those in services, as well as webinars that can be watched at a volunteer's leisure. Prior to the 1st of October, it was only 6 in services a year. That was changed by the federal government. We did not have a say in that. It is a big deal. I mean, 18 hours of continuing education for ombudsman as compared to, say, a social worker is much stricter requirement. I believe social workers only have to have 8 to 10 hours of continuing education, but ombudsman must have those 18 hours. But again, the program staff does provide numerous opportunities throughout the year to meet that requirement. So at this time, I'd love to take your questions, comments, concerns, etc. I do also have specific information on how to advocate for your loved one during COVID-19 that I can discuss as well. So please, at this point, I would like to open the floor to those questions. I think everybody's muted. Kimberly, can you unmute or?
Everybody's
Okay,
muted.
Okay.
Yeah, I can unmute, but it's I would prefer not to unmute everyone, but if anyone has a question, I certainly have a number of questions from folks that had asked me questions to ask you, so we can start
Absolutely.
there. If anyone can unmute themselves, though. If you have questions, if you have a question, you can feel free to unmute yourself. But and I will say this: one of the issues that folks that I work with have is that you know, one of the things I loved about your presentation was giving the caregivers and the family members those things that they should do in order to stay involved with the care. I have rarely spoken to anyone who was actually invited to a care plan meeting, and certainly not during COVID, but trying to reach a social worker has been a huge issue, or even a nurse. Having someone call you back is a huge issue. So family members who want to stay involved are find it very frustrating to do so, because there's a lack of communication from the facilities in general. And even when you know, I mean, some of the caregivers that I work with do make a concerted effort to reach out to the nursing staff and the social work staff, so they know who to contact, and they just don't get responses. So it's a huge issue. And so my question is just, are the family councils helpful with that? What is the purpose of the family council? Because the family member is feeling isolated, and the lack of communication coming from the facility is jarring. So tell us a little bit more about that, if you would.
Family councils are just, I can't stress it enough. If your facility has a family council, please participate, please join, because it's a nice opportunity for the caregivers to come together and share their experiences and talk about, what issues are they seeing. And as a group collectively, they can invite administration, social workers, et cetera, to come in and speak to them and address these issues. I'm sure if one family member is seeing a problem, I guarantee other family members are seeing the same thing. So sadly, not a lot of facilities have family councils. I know Van Dyne has a fantastic, strong family council, as well as Bishop. That's something when family members call me and I know it's at a facility where there is not a family council, I always ask, is that something you're willing to participate in? Are you willing to lead up a family council? And if so, we actually have a lot of resources to get that group started. So I'd be, if anyone, wants to start one at their facility, I do encourage them to contact our office, and we can give them lots of resources on how to set it up. Usually there has to be a president of the family council, as well as like a secretary. It's kind of like any other type of leadership, where there's a president, vice president, secretary, et cetera, to take notes. And it's a great opportunity to gather at a facility or through Zoom and talk about issues that you're all seeing. And again, you would be able to invite staff members to come and speak to those issues. And I do like to point out again that staff and facility staff, as well as ombudsman, they have to be invited. So pretty much the facilities I work with, do have an open invite to the ombudsman, which is great, but they certainly don't have to. It's their group and they run it as they see fit.
Okay, so the staff members don't have to attend, though, right?
No,
they're
absolutely
invited,
not.
they don't have to. So okay,
Correct.
So they could just bow out of that as well.
Well, sure. And what's nice is, so for example, Onondaga Center in Minoa, they have a very, very strong family council. And what they do is every single Tuesday, they have like basically I don't know how they call it, like a teleconference, that's how they call it, where the administrator will actually, there's a number you can call in, and the administrator at that point gives an update as to what's going on in the facility, what's the current COVID count, what's the current visitation policy, whatnot. And that was established through the family council. that family council also on their own holds meetings once a month. So they have the two things. They're able to have family council meetings with just the family members, as well as they were able to have the facility agree to a weekly teleconference to keep family members informed of the what is going on in the facility in that particular week.
Okay. Okay, so, okay, I kind of get that. But it seems as if in many instances, it's the families getting together discussing what's wrong.
Right, and solutions.
No one there to, okay, if they,
Right. But what's nice though is that, I've had family councils, if things were good and, they also do things for the facilities. I had a family
Okay.
council do a fundraiser to purchase games and different activities for that department for residents. So it's not just a group that comes together and complains, it's also a group that can come together and make positive changes for the residents.
Okay, excellent. Okay, I really like that concept. I just, we'll need to, bring that up to the caregivers that I talk with. So another concern, and it's a big one, is when you're caring for someone who is vulnerable and frail, whether they're at a doctor's visit or have a visit from you, an ombudsman in a facility, because a family member has filed a complaint or said, gosh, I see this going on. Can we do something? And the resident is afraid, shies away. Oh, no, everything's okay. Which we see over and over again when that vulnerable person is in the presence of someone with authority over them. And so in these instances, the concern of the family is that their concerns will be dismissed because the resident is afraid. And when that happens, what can the ombudsman program do? Do they have meetings with both the family member and the resident? Do they try and I guess not convince, but ameliorate in some way the fears and concerns of the resident so that genuine concerns can be met?
Absolutely. So let's say, for an example, a family member calls the hotline and they say, I'm concerned about my loved one. I'll use the example again that, they're so short staffed that, my loved one feels that when they're getting them up in the morning and getting them dressed, they're a little rough. And, I don't think they're doing it on purpose, but it's uncomfortable. I would then, of course, first thing I would do is go in person, meet with that resident, talk about their concerns. If they say, well, it happens, but I'm so afraid. I don't want to be retaliated against. There are things that we can do as ombudsmen to address these issues on more of like systematic for the whole facility. And we're able to do that without giving administration any identifying information. We can talk in generics. It's confidential program and we must have permission from the resident. It doesn't matter, if the family member says this is an issue, has to be looked at. If a resident does not want the issue investigated, we have to abide by that. However, though, there's things ombudsman can do, which you learn about in the 40 hours of training, that can address these concerns while keeping the identity of the resident confidential.
Okay.
Because I guarantee if one resident is experiencing it, so are others.
So
at that point, sorry, go ahead.
So, well, then your position then, the ombudsman, is to address that specific concern that the resident is really not wanting to bring forward, but the family member does, with the administration and the staff as a generic basis. We're seeing this happening in your facility, and there's no names brought up. That's the way that they're addressed.
Yes, absolutely. And generally when we get something like that we expect that or we suspect that other residents are experiencing, the same issue, I'll go and speak to the residents on that floor. I'll go room to room. I'll ask them if this is happening. And then I might find a resident that is willing to come forward. But even if I get a whole floor of residents that say, no, I don't want this known, again, there are ways that we can go around it. That there are ways that we can help advocate, assist these residents in need without breaking confidentiality. And that is something that is gone over in that extensive ombudsman certification training.
Okay.
We can be creative.
Okay. Okay, because I know it's a concern of family members who know
Absolutely.
that their loved ones, whether they're at a doctor's office or not, oh, no, everything is fine. Their tendency is to minimize any kind of issues that are going on. It just is, as I'm sure you're fully aware of. So I wanted to touch base again on the care plan meetings because that and that one slide I think is just a great resource that probably everyone in this class should probably have.
Sure.
We can discuss what we can provide that would be really beneficial for them, after the class. But how does a family member know when a care plan is taking place? And I'm assuming that they have to be revisited within a certain period of time.
Yes. So that's why I try to put the emphasis on when a resident is first admitted into a facility, whether it be for rehab or long-term care, to immediately, a care plan must be put in place within 7 days of admission. So usually that first initial care plan is done just by the staff, just by the interdisciplinary staff, which, would consist of the social worker, the dietitian, therapy, rec, anyone that's a part of their care. At that point, they put together the initial care plan. And then, as stated, these care plans are then reviewed every 3 months.
Okay.
So what I encourage family members and residents to do is contact their social worker and say, okay, well, for the next care plan meeting, I would like to be involved. And that is noted in their chart. And therefore, when the social worker goes to schedule that 3-month update, they know to call the family and involve them in that as well as the resident. Now, again, I'd like to point out, if there is any problem at any time, a family member or the resident can request a care plan meeting. It doesn't have to wait for those 90 days. So maybe they had a care plan meeting 3 weeks ago, but the resident may feel there's certain things that are not happening in the care plan, or maybe some new issues have arose that should be put in the care plan. At that point, they can request a new meeting to be held, and by law, the facility must accommodate that.
Okay. Well, that's excellent. That's really good to know, because I don't think that's something that most caregivers have any idea about.
No, it's not. And that really should be in their admissions packet.
Yeah.
I know. And again, it's something, trust me, we push for, we speak with administration about, but if they're not mandated, it's sometimes challenging. Some administrators are great. They take our suggestions, they work with us, and then there's others that don't love us in facilities.
Yeah, I can imagine, certainly. So I know we're running really late. It's at 7:20 now, but I wanted to ask about the surveys. Were they done in the last year and a half? Have the surveys been continuing through COVID? So will they be reflected on the website? I do refer people to that when they're when I do encourage folks to plan ahead with them in terms of a facility.
Well, sadly, through COVID, specifically March of, again, 2020 to January 2021, survey teams were not going in and doing their annual surveys. They were only going in on complaint investigations. And that was just simply to reduce the risk of spreading COVID. However, now they're back up and running, and DOH is not denied access or admission to facilities. They can also come in when they please. So thankfully now we're seeing those routine yearly assessments taking place now. And that's why you're probably seeing, in the paper or hearing about, some of these recent inspections and what they're finding. So there's been some publicity, regarding that.
I know they were back recently, but if a family member is going to look at the last 9 months or year of to see, what was going on in the facility, they're not going to see it, right?
Not necessarily.
No.
They're working very, very fast to get into every facility, but
Okay.
at this point, they probably have not hit all the major ones.
Okay. And one more question, just very quickly regarding rehab. When a family member is in the hospital and being discharged to a rehab, did you indicate that the family member had a choice of where to go?
That was on the slides I could not pull up, so my apologies. It's prior to COVID. Families and residents were able to actually choose from a list, and the discharge planner at the hospital would provide that. So they would have the opportunity to say, okay, well, there's a bed here. This is my preference. And then it goes to the facility. If the facility feels that they can meet that level of care, for example, there are not a lot of facilities in my region that have a ventilator unit. So a facility may not be able to accommodate that particular resident, but another facility can. So that's a big part of it. A facility does have the right to refuse admission if they feel they cannot safely meet the needs of that resident. Also, we are seeing more and more that there are residents going into facilities that do not speak English. And a facility has a responsibility to supply a translator so that a resident can have her needs or his or her needs listened to and taken care of. And we are finding right now that has not been happening, and we're working on that. We actually have a case at a facility where the facility never got any type of interpreter, and that poor resident was very isolated for about 3 months.
Wow.
So yeah, it's sad.
Yeah, it is. That's, I'm glad. That's another reason I'm really glad the Ombudsman program is there. I will say though that often with caregivers that I speak with, they're given they give their preference, but they're not, no, they're going here. No, they're going here. So
right. And,
really,
and since COVID, it's very, very hard. Like I mentioned, I have facilities that have partially closed the rehab units. Right now, for residents in long-term care, they do not have the opportunity to do a lateral transfer because facilities are short-staffed right now, and they're very leery of taking on a lateral transfer.
Yeah, what a shame. What a shame. Okay,
I know.
So that's why we're really, really glad that you're here, that this program is here. And I hope that anyone who's on the class that is caring for someone who lives in a facility takes heart, make sure that they connect with their local ombudsman, even before anything goes wrong, or I shouldn't say even before anything goes wrong, because it might not go wrong, but even when, there's no concern, just to be able to connect with the ombudsman program, know that they're there, and even talk with them more one-on-one about what they can do. So, and every facility does have an ombudsman.
Well, might not have a volunteer ombudsman. If they don't have a volunteer, it's me. So, but something really, I just want to show this briefly, if I may. Something kind of exciting this past year is that, all programs are underfunded. That's just the reality of it. Like I said, our federal funding is pretty good, but our state funding is really dismal. So that's why New York State in particular depends on volunteers. But I did receive a small pot of money through the CARES Act to be able to purchase promotional material, outreach material, etc. And one thing I'm very proud of is, in addition to the brochure that we hand out to residents, I had this bookmark made. I can't really see it that well. And it's perfect because on one side, it says residents have rights. It has our phone number. For more information of other resources, it gives that. But then on the back is a very simplified list of resident rights. Okay. So you have the right to be fully informed, voice your concerns, privacy, confidentiality, make your own choices, dignity, and respect. So these are nice laminated. They can use them as bookmarks, and it reminds residents these are their rights and to contact us if they are not being met.
You'll have to give us some of those.
Absolutely.
So I can provide them to other people. Well, I
Sure.
thank you very much, Rebecca. I have other questions. So the next time we do a class, I think we'll focus maybe more on those, concerns that, directly impact the caregivers so that we have time to address them. But I so appreciate the Ombudsman program and you and your hardworking staff. I mean, you do amazing work with the number of people that you have and the number of facilities that you're covering, and you're always calm and you're always willing to help and talk. So I really, really appreciate you. And I thank you all so much for attending, and we'll do some additional education. So, okay.
Yes.
Good night, Mary Ann.
Thank you, everybody, for having me. You guys have a great night. And again, please reach out to my office for anything, even if it's just information and assisting.
Yeah, right. I know. I encourage people just to get to know the Ombudsman program. Okay. Good night, everyone. Thank you so much. Well, there'll be like a little evaluation. So we'll provide that for you and to you also, Rebecca. We'll
All right,
talk
great.
soon. Okay.